Thank you all for having us. Hope everybody can hear me okay. I'm Chris Jackson, and it is a pleasure to do this with the wonderful Dr. Burrows Ray, talking about a topic near and dear to both of us in the spaces in which we work, which is thinking about burnout, wellness, and change. And so I'm going to share my screen here. Hopefully everybody can see my screen okay. So this is a clinician's prescription for well-being. So to start off, we have a few objectives that I think are important. We want to define physician burnout, try to identify the major contributors to physician burnout, review some theoretical frameworks for the mitigation of burnout, and then evaluate what are those system, organizational, and individual practices that can reduce the impact of burnout. I'll be taking on the first couple of objectives, and then my wonderful colleague, Dr. Burrows Ray, will kind of pick up and take the last two objectives that we have listed here on this slide. Again, as Jennifer Price mentioned, we have no relevant financial disclosures for the content of this presentation. I will give the exposure that, or the disclosure that Dr. Burrows Ray will probably say that this is her jam. And so you will find out why a little bit later. So let's talk about the scope of physician burnout. Like a good internist, it always starts at looking at the chief concern and kind of getting some details about the kind of history of present illness, if I can use that framing. So we define burnout as this complex interplay of emotional exhaustion, work-life integration and how successful one is at it, and depersonalization. And when you think about this interplay, I think it's important to know that as we see more emotional exhaustion or more depersonalization with less success of work-life integration, those are the scenarios under which we are more likely to have anyone, but particularly those that are in healthcare, experience what we would define as burnout. And there are different tools that can assess this. And as we go into the next couple of slides where we share some data, I want to say, or I want to show why burnout is not just kind of a buzz term, but why it actually has important implications for us personally, but also in the care that we give to patients. So this was a study done in 2022, published in September in Mayo Clinic Proceedings, looking at rates of emotional exhaustion and depersonalization amongst physicians. And I think it would come as no surprise with the COVID pandemic, with consistent demands on our clinical time, with the toll of death and other things that physicians and other healthcare practitioners have faced, that emotional exhaustion rates have been on a steady rise between 2020 and 2021. And also the feelings of depersonalization, just like not feeling like yourself in the job and workplace, have also increased. To give some perspective on numbers of how bad this is, I believe for emotional exhaustion, there's been over a 30% increase in average scores for emotional exhaustion amongst practicing physicians that participated in this burnout survey. And when you get to depersonalization, it's almost double that at 60%. So again, if there's a lot of emotional exhaustion, a lot of depersonalization, we have a lot of things on one side of that equation that are contributing significantly to burnout. Unfortunately, the personal accomplishment and work-life balance, or what I would define better as work-life integration, is lagging behind. And so if emotional exhaustion and depersonalization are the major drivers of burnout, work-life integration is probably one of the bigger protective factors. And so we've also seen from 2020 to 2021 and even 2022 a significant decrease in satisfaction with work-life integration. And with that decreased satisfaction and work-life integration, losing, again, a very important protective mitigating factor for dealing with burnout. Now, just to show that the extent of burnout kind of varies when you kind of add on other layers, at present, this survey showed about 63% of practicing physicians experience one symptom of burnout. Women physicians are twice as likely to experience burnout, and I think there are, of course, multiple contributing factors to that that we could discuss later on in this presentation if there are questions about it. Now, when we look across resident physicians, medical students, and then those that are in practice, there are some variations, and the symptoms of burnout are highest in our resident physicians. And I would say Dr. Burrows-Ray and I see this, unfortunately, on a day-to-day basis, and really informs a lot of work that I know Dr. Burrows-Ray has done at the College of Medicine level and at the local level in her program. And while I wish that we could just talk about burnout and the fact that it is a occupational hazard of our practice, and I wish people would do things just because of that, it is also extraordinarily expensive to replace one physician. And so one study showed that it can cost up to $1 million to replace one physician. And if you think about 63% of practicing physicians experiencing burnout, I think you can very quickly see how that equates to a large cost to the healthcare system if there are not intentional steps taken to try to reduce this. And if I left it there, I think you could say, oh my goodness, that is terrible, that is awful. But there's even something else that is really important to me, and that is how it impacts the way we care for patients. So these are 3 studies really looking amongst resident physicians, pediatric space, internal medicine space, et cetera, and looking at how burnout impacts the care we give to patients that are underrepresented or historically excluded in medicine. And as a Black man in medicine that takes care of patients in a clinic where the vast majority of them are Black and have varying levels of access to the medical system, whether due to costs or whether due to money or other things, these data are actually quite concerning. And what they show essentially is that when burnout rates are higher, so there's more emotional exhaustion, there's more depersonalization, there is actually higher explicit and implicit bias against patients that are in a non-majority group, often in these studies, often Black patients. And there was harmful medical errors were increased in this. Again, more outward explicit and implicit bias, and actually more lapses in professionalism and things. And so it's not just that burnout affects kind of personal level and our ability to be able to enjoy the work that we do. It also has a large impact, or the ability to impact, how we care for our patients. And for me, those 2 things together are the ultimate call to action to say that this is something that needs to be addressed. And that is what we hope as we transition, to the next part of this presentation, is to say, like, sure, there are multiple ways to measure and quantify burnout, but the goal is not just to measure it for the sake of measuring it, but really to figure out, okay, now that we know this data and we know some of the drivers of it, what do we do next? And with that, I'll stop my share and I'll turn it over to my colleague, Dr. Burrows-Ray.
Thank you so much, Dr. Jackson. I will switch over and share my screen. There we go. All right. So thank you so much, Dr. Jackson, for really characterizing the problem of burnout and helping us conceptualize not only its impact on the individual healthcare workers, but also the patients we care for and our ability to have that work-life integration. So now what? We told you it's a problem. What are we going to do about it? So let's take a shift. So when we talk about burnout, usually I'm thinking of this as a symptom of a problem. And Dr. Jackson is an amazing outpatient physician. He's like, cool, it's a problem, but I want to prevent the problem in the first place. And that's where well-being and wellness come in. And there actually are ways of preventing burnout from happening in the first place, as opposed to trying to treat it. So let's define what wellness is so that we have this kind of shared definition. So this is considered a state of personal fulfillment and engagement that leads to joy in practice and a reconnection to the why. Why did we go in this in the first place? So think back to that personal statement that you wrote when you applied to medical school and you told this medical school admissions committee all the things that you wanted to do as a physician. So really reconnecting to that. So I talk a lot about wellness, and as Dr. Jackson mentioned, wellness is my jam. And oftentimes I think it gets noted or viewed as a buzzword. And so when I start talking about it, sometimes people get this glazed look over their face. And in my mind, this is kind of what they're thinking of as I'm telling them about wellness. And it's a short clip from Parks and Rec that we're going to watch here.
Donatella, feed mobile. 3 words for you. Treat yourself. Treat yourself 2011. Once a year, Donna and I spend a day treating ourselves. What do we treat ourselves to? Clothes. Treat yourself. Fragrances. Treat yourself. Massages. Treat yourself. Mimosa. Treat yourself. Fine leather goods. Treat yourself. It's the best day of the year. The best day of the year.
So oftentimes when people think of wellness, they think it's going to be this one day out of the year that I'm just going to splurge and indulge in all the things that I enjoy doing. But in reality, wellness is something that we should be cultivating and should be intentionally doing every day. And so I'm going to kind of challenge us to think about that as we continue in this presentation. So how do we achieve physician well-being? So the first thing to highlight is that burnout is a workplace or an occupational phenomenon. It is because of the work that we do. You cannot be burnt out at home, spoiler alert. Therefore, ultimately, the way that we combat this is to really find that alignment of values between the individual and the workplace, that they're working together as opposed to working against one another. So let's take a step back and let's actually look at some theories that evaluated and thought about how burnout impacts individuals on an occupational level and what ways we can potentially mitigate this. And so this also highlights the fact that burnout can be seen in other industries outside of medicine and kind of allows us to see what are some ways for us to intervene. So the first theory that I want to introduce is the job demand control support model, which is over here on the left-hand side. And it has control on the y-axis and demand on the x-axis, highlighting the 2 aspects of an occupation that interact to really lead to burnout. So if we start at the bottom left, we see that a job with low control and low demands is really considered passive. So if you were to think of a factory with an assembly line, the person that puts the caps on the toothpaste is someone who has low control. They're not deciding what color the cap is or what cap it is. And it's pretty low demand. You're just putting a cap on a toothpaste and that's it, nothing else. And you can see this diagonal line that's present that kind of goes from this bottom left-hand corner up to the top right. And that top right corner is actually an area that shows high demand and high control. So even though you're in an environment where you have a lot of responsibility, you have a lot of control over what you're doing. And so that's actually a space where people learn and grow and are motivated to do more because they have control over how do I solve this problem. And so that's usually what we think about with physicians or even lawyers. And as you see that arrow, it demonstrates that you have more learning in that specific quadrant. Conversely, if you look at a job that has high control but low demand, there's not a lot of strain. So going back to that factory analogy, the person that is experiencing this low strain or low demand is someone that's the foreman. So you're standing there, you're watching everything that's happening, and you have control to change or to fix things as you see them, but you're not really doing a whole lot. You're not really on the assembly line. And as you see, there's a diagonal that goes from that top left corner down to the bottom right. And this is considered strain. And this is also kind of viewed equivocal to burnout. And what we see is a job that has low control and high demand leads to high strain. And I would argue that residency pretty much perfectly articulates that. You have high demands, you have these new responsibilities as a physician, you're caring for patients, putting in orders, writing prescriptions, but you don't have a lot of control over your schedule. The program's telling you where to be, when to be there, and how long to be there. So it's not surprising that our residents and fellows are experiencing higher levels of burnout compared to our other practicing physicians and even medical students. So I just told you that burnout is bad and that residents are experiencing quite a bit of it. So how do we mitigate that? And so this next model on the far right demonstrates how social support can actually act as a buffer for what we see in these jobs where there is high demand. So starting here, we see job demand being high leads to either burnout or work engagement. And that's really dependent on the amount of job control you have. If you have less control, you're going to be burnt out. More control, you're going to be more engaged. However, when you include social support, whether it's emotional or instrumental, such as resources, it actually mitigates how much burnout is actually generated. So we have the ability to intervene and impact these systems through social support. Let's take one step just a little bit further, and then I'll step away from theories. I know you guys probably weren't expecting this tonight. So let's talk about those resources that they mentioned when they talked about support, instrumental support. So in this diagram, we see job or personal resources as well as job demands that are kind of our starting points. And for job demands, once again, high job demands leads to strain, which will impact your job performance. And this kind of recurring cycle that you see here is considered a loss spiral. So let's say you have a job with high demands, thinking about working during COVID, lots of patients that are very sick, trying to navigate that, and you're under a lot of strain. And you may start to question, am I doing the right thing? Or do I even know what I'm doing? Which I would argue we all probably had that thought at some point during the COVID epidemic or pandemic, when we were constantly getting new protocols that were being generated, as well as new guidelines from the CDC. And so unfortunately, when we're under a lot of strain, we are more likely to make those medical errors. And when we do make those medical errors, then that kind of reinforces that, do I even know what I'm doing? And kind of leads to that loss spiral. Conversely, when you have resources, and as we talked about, even if you have a high job demand, you're going to feel like you have more control and you're going to be more motivated to do so. As a result, you'll be able to kind of enter that creative space, that problem solving space, and really generate that job crafting. And this is considered a gain spiral. So essentially, this is self-perpetuating, and actually you are more productive, even if you are experiencing high demands. So let's take a look at what that looks like for a physician. So when we think about job demands, what we're really thinking about is being overworked, the amount of patients that you're having to see, time pressures, how quickly are you getting patients discharged from the hospital, how quickly is that clinic visit ending, role conflict. You may view your role in one lens and the organization may view it differently. And so there may be some conflict where you would rather spend time at the bedside with your patients as opposed to filling out another form or doing some other form of documentation required by the organization, or even role ambiguity and not feeling sure where you fit in the larger organization. And then thinking about resources, what things can we use to help mitigate burnout? Professional development opportunities, things that help us grow as an individual to feel more competent in what we're doing, mentorship programs, getting that timely feedback, and having supportive leadership. So these are all resources or things that we can do to help mitigate burnout in the first place for physicians in particular. So theories are interesting, but we work in a healthcare system. How am I supposed to apply these theories to where I work and actually get something meaningful from it? So I want to kind of talk about the levels of well-being and address ways that we can intervene on those specific levels and highlight the fact that there is more to it than it might initially seem. So let's first start off with our system level. So this is Dr. Vivek Murth. He is our U.S. Surgeon General. And in May of 2022, he released an advisory on health worker burnout and well-being. So when the U.S. Surgeon General releases an advisory, he is saying, red alert, this is a priority. This is a public health issue and problem, and we need to put this in the forefront and address it. And I would argue that with the COVID pandemic, strains in our physician and healthcare workforce were further magnified, and it became clear that this was a problem that was not going to go away on its own, and that was impacting the nation's health overall. So in this advisory, he also produced some steps that a organization or that us as a nation could do to help improve or mitigate healthcare worker burnout. So first was protecting the health and safety of our healthcare workers, making sure they have a safe environment that they can work in. Eliminating punitive policies for seeking help. Physicians are constantly telling our patients, oh no, this is bad. You should seek help. You should go to counseling. You should go to substance abuse help if you need it. However, what you saw were there were policies in place where physicians were being penalized if they did seek help. And so removing that stigma and acknowledging the fact that physicians are humans too, so they should have the same access to those resources and help. Removing those administrative burdens, really transforming the culture to prioritize healthcare worker well-being, and recognizing the importance of social connection and community. We are social. We do better when we are around others, and isolation can be, as Dr. Jackson mentioned, additive when we talk about burnout because you feel like you're the only one experiencing those signs or symptoms. And I think COVID further illustrated that isolation is not great for anyone, physician or otherwise. And this diagram just kind of illustrates that in order for us to achieve this, we have to have our stakeholders, which are these roots here. And we need to have this trunk of trust that kind of leads up to these initiatives that allow us to actually support our physicians or our healthcare workers in combating burnout, recognizing that there are multiple individuals that are involved in impacting healthcare worker burnout that we need to mitigate. So this is Dr. Lorna Breen. She was an emergency department director at New York Presbyterian Hospital in Manhattan, and she was on the front lines of the COVID-19 pandemic. She was there for 12-plus-hour shifts with little PPE, trying to care for the patients in her community. She discussed with family and friends the isolation that she felt, as well as feelings that she knew she needed to seek help, but was reluctant to do so because of the negative repercussions potentially of having to say that I did seek, whether it was mental health counseling or some other intervention when applying for credentials. She died secondary to suicide, and her family has rallied in behind the person that they knew and loved and who gave so much to medicine to try to create legislation to prevent this from happening to other physicians, and acknowledging the fact that this is an issue across the nation that needs to be addressed. They were able to pass the Dr. Lorna Breen Healthcare Provider Protection Act in Congress, and it really tries to give weight and a structure to how do we address this for physicians. So providing grants for training so that students, residents, as well as healthcare professionals can recognize and identify strategies for mitigating burnout, looking at evidence-based best practices and disseminating them, creating national educational awareness programs and campaigns, additional funding for education, peer support programming, and ultimately creating a comprehensive study to really characterize this problem that exists. And so creating a framework that allows us to better quantify this problem and actually address it on a system level, which is huge and something that we hadn't really seen prior to this. So we're going to take a step down and we're going to go to the organizational level. And this is probably a level we're more familiar with. So we're thinking about your employers, essentially, whether it's a hospital, a clinic, or even a community setting. So the National Academy of Medicine created an action collaborative on physician well-being and resilience. Their job is to advise the nation on health, healthcare, as well as biomedical science and technology, and determine what would be best in kind of moving forward those goals. And in this instance, it was specifically physician well-being and resilience. And they developed these 6 domains of organizational evidence-based practices. So they're saying, hey, organization, here are 6 things that you can do right now to actually mitigate the burnout your physicians are experiencing. And so first and foremost is acknowledging that you are committed to doing this. So doing more than just saying, we have a well-being initiative, this is great. Do you actually have someone in a leadership role who is taking this on and has ownership of that? Do you have a chief wellness officer? Strengthening leadership behaviors, recognizing that physicians on the front lines taking care of patients in the hospital, in the clinic setting, are the ones that are seeing the problems. Therefore, they are best poised to be able to find solutions to those problems. So how do we get them into leadership positions where they can have a voice at the table? Doing an assessment. How bad is the problem? Does it exist? Examining policies and practices. Are there things that we can eliminate that add to strain or that add to that list of things that need to be done, but they don't actually help or impact our patient care? Thinking about the deficiency as well, and then really cultivating a culture of connection and support. So once again, that idea of community and really creating those connections between one another. So how do we implement organizational interventions? It's great to have these amazing domains. It's great to have these awesome thoughts and theories, but how do we actually make this happen in real time? And I think this is often where we struggle, right? This is where the rubber meets the road, and we try to turn these ideas into actions. So they released the 2022 Healthcare Workforce Rescue Package, and they said, hey, organization, here are 5 things you can do right now in this moment to actually improve or mitigate the burnout your physicians are feeling. The first was just acknowledge the fact that during COVID, those were not normal times, and we should adjust our expectations. We were likely not going to be, if you were in an academic setting, you weren't going to be doing a bunch of scholarly activity. Why? Because clinical care was number 1 and we had lots of patients to care for. Or conversely, as a pediatrician, we saw in the hospital less and less patients. We had a drop in the census in the number of kiddos that were coming into the hospital because they weren't going to daycare. They were pretty much just at home, so they weren't really getting sick. Conversely, on the adult side, we had all the patients over there. Next, getting rid of stupid stuff. What are the things that you have to do every day that don't add to you as an individual or add to the care that you're providing your patient? One of my mentors, Dr. Mukta Panda, describes this as the pebble in your shoe. What is that thing that's just annoying and that if you could just eliminate it from your day, it would make your day 10 times better? Designating a well-being executive, once again, having someone in leadership to advocate for these interventions. Get radical, shoring up staffing. Staffing was a huge issue during the COVID pandemic. So taking people that were primarily non-clinical and shifting them back into a clinical role, or individuals in leadership positions and kind of shunting them back to those front lines to help us provide the clinical care our patients needed. And last but not least, recognizing that the employee assistance program isn't enough, and that we need to be more intentional. And that includes providing resources for mental health, providing substance abuse counseling. So providing additional resources for our physicians who are in need so that they aren't having to try to navigate these things on their own. So let's take a closer look and say, well, we've talked about these organizational level interventions and these 6 domains. So how can we look at these in real time? So here are just a few examples of things that I could think of in these different settings that demonstrate ways to impact wellness on an organizational level. So first and foremost, thinking about an intensive care unit or the ICU setting. So providing practical communication training. You have patients that are critically ill with family members who are distraught, who are probably overwhelmed, are hearing what you're saying, but we'll probably have to have you repeat it 2 to 3 times because they're processing multiple things simultaneously. And if you're the primary provider, you're also navigating different consultants and making sure that you have clear, honest communication with your patients. And so providing that communication training to ensure that everyone's using the same language, the same tools, and that you're able to communicate with one another clearly so that things aren't lost and no further harm is caused to the patient. Next is thinking about team-based interventions like team debriefings. Debriefings count as wellness. Why? Because we're taking time and space to process something that has happened emotionally. We're being very mindful, we're being present in this moment to think about what it is. For better or for worse, physicians are often trained that when something happens, you put it in a box, you keep going, and maybe one day you come back to the box, but probably not. And that's fine. Just keep going. There's another patient to see. But in reality, we should acknowledge the fact that we are humans who are experiencing a situation and that it's okay to have emotions secondary to that situation and to process that and talk to others. And then last is to provide activities to promote team bonding. So maybe not always doing things in a clinical setting. Maybe instead of starting the day with, all right, we're going to start rounds and start with our first patient, maybe you start with, what's your favorite dessert? Or maybe it's a hot take. Who has the best coffee? And so really giving your team a chance to bond over things other than medicine and get to know one another as humans. So next, let's talk about family medicine. And so in this perspective piece, they discuss how they attempted to kind of redesign care in a manner that increased the amount of time that physicians spent doing things that added to themselves and to patient care, and removing some of the tasks that didn't necessarily require the problem solving that we think of when we talk about clinical decision making. And so what they did was they used medical assistants to assist with daily tasks, history taking, reconciling medications, scheduling visits, administering vaccines. And what they noted was that there was a decrease in burnout rates from 53% to 13%. So just by shifting these tasks that need to be done for every patient to the medical assistants and allowing physicians more time and space to do the thing that they enjoy and love, spending time with their patient and really hearing what's going on, providing that additional counseling, they were significantly more satisfied with what they were doing. And they were able to reconnect to that why of why they joined medicine in the first place. And I would be remiss if I didn't include one inpatient example as an inpatient hospitalist. And so thinking about internal medicine hospitalist, having discharge rounds in the morning to discuss my barriers with case management and social work are huge. It allows them to know the things that are preventing me from discharging a patient, for them to help me, and then for us to expedite that discharge in a timely manner so that my patient isn't in the hospital longer than they need to be. Having a streamlined and centralized mechanism for contacting team members Sometimes we've got lots of consultants, I've got lots of physicians involved, and it can be difficult trying to contact a physician, despite the fact that we all have cell phones. So having a centralized directory where I can see who's on call, what their contact number is, allows me to quickly communicate with that physician, find out if there are any questions that they have or any questions that I have, and be able to provide the care for my patient as opposed to trying to read notes when they get written, doing those things in real time. And once again, having that connection with another physician. And then lastly, having nursing staff present during bedside rounds. We are a team, and in the inpatient setting, I am only as strong as the weakest member of my team, and that encompasses those beyond physicians. And so having nursing at the bedside with me ensures that I'm aware of any day-to-day things that maybe don't get written down or aren't being reflected in the vital signs, and that I can address them in a timely manner. And so it allows me to provide the best care for my patient within this clinical setting. So we've talked about some ways that we could implement these organizational level wellness. And I just want to kind of leave with a few do's and don'ts to remind ourselves that, yes, this might feel overwhelming, but there are still small steps that you can take to move towards kind of shifting that needle when we talk about organizational wellness. And I kind of want to focus on the do's because I'm a positive person. So what are the things that we should be doing? So focusing on the bright spots. What are your assets? It's easier to make a list of your, actually, it's harder to make a list of your assets. It's always easier to make a list of the things that you don't like. So challenge yourself. What things are you doing well? Focus on systems interventions. Try not to get bogged down by pointing fingers at, well, if you only did this, then this would be so much better. That's not going to fix the problem. Committing to a culture and system transformation. So recognizing it's probably going to take some time, working together to create those solutions, and focusing on measurements that are specific and timely and that address what you were interested in. You can measure a lot of things. We've all gotten lots of surveys. However, I would argue if you are more targeted in what you're trying to address and measure, it's easier to come back and say, look at the results of what we've done. Look at what we've been able to implement. So let's shift gears to individual level. And this is often what we hear about when we talk about wellness and well-being and ways that we can improve our wellness. I will give the caveat that research has shown that organizational level interventions are more impactful compared to individual level, and so you get the most bang for your buck. However, I do want to be complete and make sure we talk about some individual level interventions that you can also do so that we are talking about all three levels. So we're going to hit on useful attitudes, gratification, as well as resilience building as kind of these three overarching things to highlight individual strategies in particular. So because I believe that wellness is active and engaging, if you are able to, we're going to take some time and create our own well-being toolkit. So this is a chance to actually use your phone during a webinar or a lecture, and it's okay, because if you put these things on a piece of paper, you're going to forget it, lose it, never look at it again. But we always have our phones. So if you use your smartphone to open a new note and label it My Wellbeing Toolkit, we're going to kind of go through these next things and hopefully give you a chance to think about what you can include in that toolkit. And I love this picture of all the cell phones as someone who actually experienced all these cell phones. It's crazy how far we have come. All right. So first and foremost, useful attitudes and ways of being. So mindfulness, and this is once again a term that often gets thrown around. Like, oh, just be mindful, and it's like, okay, what does that even mean? So mindfulness is being present in this moment, looking at the slide, at the image I have on the slide, listening to my voice, and being present as we talk about wellness and well-being here in this moment. Not thinking about the notes you need to write, not thinking about the patient that yelled at you earlier today, or worrying about what you're going to eat for dinner. So just really being present in this moment. It's a bit nebulous, I'll be honest. And sometimes I still have trouble grappling with mindfulness. So this video, in my mind, is a great illustration of what mindfulness is and its potential impact on improving our wellness and well-being.
You may have heard this word mindfulness. It's become something of a buzz phrase of late. I'm going to give you one simple, serviceable definition, which is this. Mindfulness is the ability to know what's happening in your head at any given moment without getting carried away by it. Imagine how useful this could be. Just as an example, driving down the road and somebody cuts you off in traffic. How do you normally react? I think most of us, we normally react by having a thought, which is, I'm pissed. And then what happens next? You immediately, habitually reflexively inhabit that thought. You actually become pissed. There's no buffer between the stimulus and your reaction. With just a little bit of mindfulness, in that same situation, you might notice my chest is buzzing, my ears are turning red, I'm having a starburst of self-righteous thoughts, I'm getting angry. But you don't necessarily have to act on it and chase that person down the road, screaming at them with your kids in the back of the car thinking you've gone nuts. Now, you might be thinking, don't I need to get angry sometimes? Aren't I justified? I would say yes, but probably not as much as you think. The proposition here is not that you should be rendered by mindfulness into some lifeless, non-judgmental blob. The proposition is that you should learn how to respond wisely to things that happen to you rather than just reacting blindly. And that, my friends, is a superpower. How do you get it? The way to get it is through meditation. I believe that meditation and mindfulness are the next big public health revolution. In the 1940s, if you told somebody you were going running, they would have said, who's chasing you? But then what happened next? The scientists swooped in, they showed that physical exercise is really good for you. And now all of us do it. And if we don't, we feel guilty about it. And that's where I think we're headed with mindfulness and meditation. It's going to join the pantheon of no-brainers like brushing your teeth, eating well, and taking the meds your doctor prescribed for you. Let me just close by saying, mindfulness is not going to solve all of your problems. It's not going to render your life a nonstop parade of unicorns and rainbows. Nonetheless, this is a superpower and one that is accessible by you immediately.
So hopefully after watching that short clip, you have a better understanding of what mindfulness is and its potential impact on actually changing how we view ourselves and our wellness and well-being. So secondly, positive psychology. So this really just is looking at the glass half full as opposed to half empty. And if you think about the National Academy of Medicine's kind of list of do's and don'ts, this is literally one of them. So really thinking about your assets and focusing on the positive qualities and attributes that you have as opposed to the negative ones. And then the last one is gratitude practice. So taking a moment to be grateful for the things that are present. There are lots of gratitude journals and other things that you can do. And one that I've done is a 5-minute journal, and it challenges you to take 5 minutes out of your day, every day, to sit with this journal. And you have a portion for the morning and a portion for the evening. It asks you to identify what are you grateful for? Think of 3 things that are going to make your day great. And then thinking of an affirmation. I am an awesome physician who cares deeply for her patients. And then in the evening, taking time to reflect on how well you were able to achieve those 3 things. I think that it's more impactful than it seems, simply because by identifying the 3 things that will make your day great, you become more intentional in actually trying to achieve those 3 things because you've thought of them and you've written them down and kind of committed to them, so to speak. So in your toolkit, think about what ways could you really implement or encourage that attitude of positive thinking, of well-being, whether it's meditation or even gratitude practice. So switching gears, we're going to talk about resilience building practices. And the first is self-care. And this is often another one that gets a bit of a bad rep or isn't as well represented as I would hope. And so the first and most important thing when you think about self-care is what is not self-care. And so if there are things that you don't like to do, not doing them is just as important as doing the things that you enjoy doing. And so we probably have all been in situations where, let's say, for instance, here in Memphis, the Grizzlies are big, or going to the playoffs, yay. If you don't like basketball, if you don't care about any type of organized sporting events, and I invite you to I'm going to invite you to playoffs. And you're like, well, I guess I'll go because it's playoffs. I'm supposed to go. There's a guy, John Morant, something. But you're going to be miserable the entire time because you don't like basketball. So true self-care would have been saying no, and instead doing something that did bring you joy, which might be reading a book or maybe watching some show on Netflix. So making sure that you're aware of the things that don't bring you joy. Otherwise, when we think about self-care, the other things that often come to mind for people are exercise, sleep, diet, as well as spending time with friends and family. And I like this idea of a circle of self-care Because if you make a list of the things that you view as self-care or that bring you joy, and you actually put them in a pie chart format, it forces you to think about just how important certain things are. I would argue that sleep is very important for me, and that has become even more of a realization with the newborn and the lack of sleep that I've been getting. So I've not been as well as I would want it, but we have been getting more sleep, so I've become more well as a result. So next, self-compassion. So thinking about self-kindness versus self-judgment. Oftentimes we're very critical of ourselves, and we tend to ruminate over things that have happened. And what this challenges you to do is, instead of ruminating on something and possibly being critical, think about what you would tell a friend who is going through a similar situation. We are often a lot kinder to our friends and are able to kind of have that self-kindness. So really kind of thinking about things in a different framework, so to speak. And also recognizing that common humanity versus isolation. Going into that rumination phase where you're just thinking and replaying that event, that patient care episode that happened, or that medical error, and not actually getting a chance to discuss that with someone is very isolating. However, having a chance to discuss that with a colleague allows you to get a different perspective and for them to acknowledge or identify whether or not there were things that could have changed, that could have been done differently. And once again, finding that common humanity with one another. And then thinking about gratification through relationships and finding meaning in work. So narrative medicine is something that has become a lot more prevalent in the past 10 or so years. And it encourages us as physicians to think about our patients and our experiences in the form of a story. And it's been shown to enhance empathy and facilitate connection with patients on a deeper level, and ultimately preventing burnout. If you think about it, physicians are storytellers. That's what we do all day. When you think about an H&P, a patient presentation, I'm telling you a story about this patient, and I'm helping you get an idea of what this patient's circumstances are, what their current health is, and what I think is going on. It would make sense that similarly, when we're thinking about our experiences with our patients or with our colleagues, that processing them in the form of a story can help us find that connection and help us think through those difficult situations, as opposed to just putting them in the box, so to speak. And then next, opportunities for physicians to gather. So creating space for us to make connections outside of medicine. So this could be facilitated discussion groups, this could be book clubs, or this could be a reception or a meet and greet at a local brewery or restaurant, but giving us the time and space to create connections and to find similarities beyond medicine. And I would argue this is probably one of the most powerful things that we can do, because it reminds us that it reminds us of our humanity. And I think it makes those conversations, whether we're stressed out or frustrated, when we know that the person on the other phone is someone that we've gotten pizza with, or our kids play with their kids, it's a very different conversation as opposed to some nameless person you've never met before that you're sending text messages to, as opposed to just having a phone call or having a conversation. So putting it all together, so you've gotten a chance to think about the 3 different levels of wellness. I've challenged you to think of a toolkit, thinking about resilience, as well as thinking about how can you create those connections with one another, and also mindfulness and positive psychology. So if you think back to our initial slide that Dr. Jackson discussed, when we described burnout and its 3 spheres, we talked about how the interaction of these spheres only makes burnout more prevalent. So let's take a step further and let's look at 3 spheres for wellness and well-being, and really identify how do we mitigate burnout and kind of bring this full circle. So the Stanford model of professional fulfillment also has 3 spheres. Culture of wellness, which, as you remember, both in the health advisory as well as National Academy of Medicine rescue package, they talk specifically about creating a culture that encourages and promotes healthcare worker wellness and makes it a priority. Efficiency of practice, that goes back to that rescue package, getting rid of stupid stuff. So allowing us to do our job to the best of our abilities without being bogged down by paperwork or other administrative tasks. And then personal and professional resilience, that goes to that individual level that we were talking about, where we were describing what things can we put in our toolkit to help us develop that individual resilience, and kind of how these three things can work together. And ultimately, having those three levels of wellness interact with one another to ultimately create professional fulfillment, which is the ideal. However, I recognize that that's not going to happen overnight, and you may find overlap between 2 out of the 3 as opposed to all 3. With that, these are our references. And at this time, we'll take any questions. We want to say thank you. And this is Emery, who is keeping us up at night, but that's okay.
They make them cute for just that reason.
That's what I'm learning.